Hello, my name is Heather Moore, and I am a graduate student in the Nurse Practitioner program at East Tennessee State University. And today we'll be discussing geriatric syndromes, but specifically syncope. So, what is geriatric syndrome? So, a geriatric syndrome is one that's commonly found in the geriatric population that can lead to significant morbidity if it is not addressed by the provider. And some of these syndromes include delirium, falls, dizziness, urinary incontinence, frailty, syncope, and pressure ulcers. But without interventions, these syndromes can lead to a sequela of other problems. For instance, incontinence can lead to pressure ulcers, which can then lead to infection. Because they're so common and tend to be perceived as normal by patients and families, they can go unnoticed and may lead to a decline in their health and cause patient suffering. According to Inoue, Studensky, Chinetti, and Kuchel in the article Geriatric Syndromes, Clinical Research and Policy Implications of a Core Geriatric Concept, there are shared risk factors among the geriatric population that tend to lead to these geriatric syndromes. And having these syndromes can then lead to frailty, which only worsens their condition and potentially can lead to more occurrences of these geriatric syndromes. So the conglomeration of all of these risks and increasing syndromes then causes poor outcomes for the patient, which can lead to a significant dependence or disability that leads to a need for long-term care facility and potentially even death. In a study performed by Ventrano, Fobel, Maragani, Brandy, Colomati, Heckman, Herdes, Burnaby, and Onder in 2017, it was found that the occurrence of geriatric syndromes increased with the degree of morbidity. Also, Goyle and Marr state that syncope has an estimated 2-year mortality and can lead to falls, which can be devastating to the older adult. And in my own clinical practice, I have found that with increasing comorbidities comes more polypharmacy, and then that can just cause or exacerbate these syndromes. So, Miss CC is an 80-year-old female patient who presented to the office with a complaint of low back pain that radiated down her left leg. She had previously been in a motor vehicle accident in October of 2018, but there was never any imaging done of her back when she was hospitalized. So the patient had an x-ray of her back in the clinic and was found to have significant degenerative disc disease with impressive scoliosis and was referred to ortho. Also noteworthy about this patient is her extensive medication list, which we will discuss on the next slide. So she has allergies to sulfa drugs, ciprofloxacin, and macrodantin. Her immunizations were really all up to date, and she tends to receive them as soon as she can. She has also been up to date on all of her preventative screenings except for her DEXA scan, which we scheduled in the office. She has a past medical history of arthritis, chronic kidney disease, COPD, fibromyalgia, GERD, hyperlipidemia, hypertension, hypothyroidism, scoliosis, and stress incontinence. Her hospitalizations include the ORIF from the motor vehicle accident that we discussed, an appendectomy, cataract removal, hysterectomy, thyroid biopsy, tonsillectomy, and total knee arthroplasty. She lives alone, and her niece lives next door, but she's been independent until recently. So, as you can see, this patient has a broad medication list with some medications that can certainly interact with each other. In studying this patient's medications, I found that amlodipine and atorvastatin can actually cause muscular abnormalities that can be either as simple as aches or as severe as rhabdomyolysis, which is possible that this interaction could be causing what is considered her chronic kidney disease and her fibromyalgia. Obviously, addressing her back pain was also important on this visit, but addressing some of her complicated medications also became a priority, and we decided to schedule an additional appointment to address some of these concerns. Some of her medications have the ability to cause severe hypotension, which is where geriatric syndromes come into play for her. With hypotension, dizziness, and syncope can occur, which can then lead to falls and morbidity. This patient is alone a majority of the time, and if she did fall, there's a risk that she would not get immediate assistance, which becomes a major concern for her. CC is actually managing her own medications independently at this time, and occasionally will have them checked by her family, but not regularly. And it's also important to note that she is prescribed 13 medications, and this is not even including the occasional over-the-counter drug that she takes. And many of them are on the Beers list, which can cause significant side effects when taken together and even alone in the geriatric population. So the patient's vital signs include a height of 5 feet 3.5 inches, weight is 135 pounds, BMI 23.5, blood pressure is 116/62, heart rate 90, respiration 16, temperature 98.1, and O2 sat of 95%. So the physical exam of the patient really mainly surrounded her orthopedic issues. It was a focused assessment. The patient's get up and go test was negative for any kind of concern with mobility. Her strength of the affected leg was 4 out of 5. She did have a positive straight leg test. She had pulses that were 2+ on the affected side. And she did not have any impaired sensation when tested with the monofilament, but she did report in the review of systems numbness and tingling of that left leg. On this visit, we did the mini mental status exam, used the frailty tool, used the geriatric depression scale, and the Tinetti gait and balance tool. All of these screenings were negative except for the frailty tool, which was positive. The frailty tool is one that is utilized in screening CC, and according to Chen, Mao, and Lang in 2014, frailty that is prevented, delayed, reversed, or slowed can prevent adverse outcomes and should be prevented or reduced at least in patients whose frailty cannot necessarily be reversed. They also go on to say that pharmacologically, there are really not any beneficial therapies to add, but that exercise and comprehensive geriatric interdisciplinary assessments can be beneficial for these patients. So the geriatric syndromes included in the differential diagnoses for this patient include incontinence, dizziness, and syncope. As stated previously, pharmacology is oftentimes not necessarily the solution to these geriatric syndromes. So to treat her possible incontinence, according to Kennedy, Malone, Fletcher, and Martin Plank in 2014, it would be recommended to start a voiding schedule and in-state bladder training, as opposed to starting a pharmacological medication first. Also, dizziness and syncope are pretty likely to occur in this patient, given her medication regimen. It includes oxycodone, duloxetine, furosemide, and diazepam, all of which have potential to cause hypotension, and the risk is only worsened by the combination of these drugs together. The concurrent use of these medications in any patient is really not recommended, but raises even more concern for a patient, first of all, with chronic kidney disease, because of her risk for impaired excretion, but also because of her age. For the final diagnosis, and considering all of the geriatric syndromes, I am most concerned for syncope for this patient. As previously determined, she is frail, and syncope could certainly lead to a fatal fall and further injury. There may be some challenges of this plan, and the patient would need to be closely monitored. The patient's current vital signs are stable. Her blood pressure was within normal limits, so there is a risk that decreasing or eliminating some of her current medications that could cause dizziness and syncope related to hypotension could then cause an unwanted elevation of her blood pressure. Also, minimizing her medications could lead to less controlled symptoms such as pain control and discomfort, sleep disturbances. So in order to combat these possible risks, it may be most advisable to reorganize the timing of the medications so that these high-risk meds are not taken all at once, and that could decrease the risk of hypotension and further syncope while minimizing the negative outcomes of the situation. Also, according to Kennedy, Malone, Fletcher, and Martin Plank in 2014, and on page 95, educating the patient at risk for syncope is important because it can potentially cause an avoidance of an event. So if the patient understands that adequate fluid intake and avoiding sudden changes is important, then we could potentially prevent a fall. So first and foremost, a plan needs to be created not only to prevent a fall, but a plan of action in the event of a fall is also necessary for this patient. It would be helpful for this patient to wear an alert button that would enable her to call for help if she would need assistance, since she is alone. Also, utilizing home health for this patient would likely be very beneficial. She certainly does not have the needs for a long-term care facility or a skilled nursing facility or anything like that. But if a fall occurred, she would likely have poor outcomes, and that may lead to needing long-term care. She also, having a nurse would probably help her to manage her medications a little bit better and evaluate vital signs before she takes some of these medications that could potentially lead her to be hypotensive. It also might be helpful to kind of make a plan for assisted living in the future as well in the event that she does need a little bit more assistance. In consideration of her lumbar radiculopathy, an orthopedist, physical therapy, and occupational therapy would be helpful in improving mobility and lessening instability related to her pain. Additionally, the patient already sees a pain specialist that helps her manage her chronic ailments. So CC is a compliant patient who genuinely cares about her health and is always making an effort to improve it. If this were not the case, her plan of care would potentially be a lot different, but she is an active participant in her health and her care and has her own best interest in mind. She has a supportive family, which she states has helped her stay independent. Financially, the patient denies any concerns and reports that when her husband passed away that he had left her money to live off of, so the cost of medications does not burden her, and she has not run into any legal or ethical dilemmas at this time. So, in conclusion, one of the most important lessons I found in my research about geriatric syndromes, most specifically syncope, is that using prescription medications as the solution for some of these syndromes can actually lead to further risk instead of improving the patient's quality of life, which is really what, as providers, we're trying to do. So, there's so many medications have side effects, especially in the older adult population, that minimizing this polypharmacy can actually lead to less problems. So evaluating medications on every visit is something that can not only cause less confusion for a patient as far as taking medication goes, but also can minimize side effects. I also think it just really showed me how beneficial non-pharmacological management of some of these syndromes can be. And I also think that I was kind of reminded about how important community resources are, as well as patient education, because making the patient and the family aware of these risks and instating a plan to minimize the risks together in a team-like fashion can actually just lead to better outcomes for the patient and their families. This concludes my presentation, and thank you for your time.